My name is Ron Ehrlich, and welcome. Today we've organised, together with my co-organiser Simon de Pomeroy. Where's Simon? He's hand up over there, Simon. Simon is a school teacher, parent, and concerned resident, and I'm a dentist, a holistic dentist, and people say, what's a holistic dentist? And basically dentistry focuses very much on the teeth and the gums, and as a holistic dentist we focus on the person attached to the teeth and the gums. So it's a small difference, but it's a significant one. When we organised this conference, it may be my naivety, but the intention was that we would, because I mean, while I'm a dentist who has been in the practice here in Sydney for 35 years, I've for most of that time, probably for the first 30 years, just accepted the fluoride as probably is okay. And then I started to explore the science myself, and I certainly don't hold myself up to be an expert, and rather selfishly tried to organise a conference where I would invite all those that were pro and all those that were against, and they would just present the science, and it would give us all an opportunity to answer the questions, ask questions. So on or about the beginning of December, I contacted the ADA and I explained to them exactly that. I said we were going to organise a conference for and against, and I wanted the best of the best to come here and present the forecast. And they introduced me to a fellow I hadn't heard of before, a guy by the name of Brendan White, who is on the ADA Council and is up in the northern New South Wales, and he speaks on behalf of the ADA on the fluoride issue. And I contacted him and said, please join us, it's going to be a very civil meeting and just exploring the science. And he said, I'm not coming. I've been to meetings like this before. I was disappointed by that, but I said to him, look, at the very least, send me your PowerPoint and I will present. And I will present the PowerPoint. And then I also rang up I also sent an email to the dental faculty, the Dean of the Dental Faculty, and I invited them and said, please send us the person that is best qualified to talk on this. And I didn't get a response for a few weeks, so I then sent an email to Professor Wendell Evans, who I know is the expert on this issue, and a day or two later I got a response from the dental faculty saying that no one was going to be attending. And some of you may have, and I was disappointed by that as well, and some of you may have read a newspaper article last week on that, and when it went out I thought, look, at least I will extend another invitation and just say, look, how about it? I guarantee that, as a moderator, I want to keep things very scientifically orientated. And then I got a response from Dr. White saying that I wasn't to use any of the presentations. And just to give you a hint, like here was the presentation that I was sent. I'm not going to use it, this is only the front slide, but when I saw the Ministry of Health, New South Wales, I realised he was not only a spokesman for the ADA, but was probably also a spokesman for New South Wales Health, rather naively. And here was the response I got just the day after or so that I spoke to the ADA, saying, hi Ron, hopefully it works this time, because he sent me 2 presentations. Call with any questions. Cheers, Brendan. Very, very friendly and very, very nice. I was disappointed that they couldn't come, or he didn't want to come, but at least I had the PowerPoint presentation, which was quite extensive. But when I sent the second invitation, sadly, at that point, I got a more formal letter. I won't put up the email now, but I got a more formal email saying, Dear Dr. Ehrlich, the ADA has no recollection of your conversation with them, and had I realised that you were going to be using this X, Y and Z, so you will need permission from the Ministry of Health, and this was all a few days, about a week ago, so I didn't have time to do that. So now I find myself in the position where, contrary to the program, we're just going to swap over a little bit, and I, ironically, am going to present the case for. And so basically, and the format for today, I should just a bit of housekeeping. Now the format for today is we've tried to make this a TEDx style event. And by that I mean 20 minutes. The biggest challenge is to say what you have to say in 20 minutes and keep it as concise as possible. Now, I'm committed as your moderator to try to keep our speakers on track. To do that, I've said to them all, you've got 20 minutes, and I will then hold up a sign which says halfway, 5 minutes, your time is up, and then I'll come and stand next to you. I mean, that's pretty pushy, okay? But we've got a lot of speakers, and we've got some tremendous speakers here today. So we've really got a lot to get through, but the main issue also was that you would have ample time to ask questions. And on top of the 5 or 6 speakers that we do have today, we've also got Dr. Charles Cranfield, who's a senior lecturer at the School of Medicine and Molecular Science, Biosciences at the University of Technology here. We've got Dr. Pri Bandara, who's a clinical researcher, formerly from Westmead Hospital, not a medical practitioner, a clinical researcher, so that wasn't quite right. And also we've got Professor Bruce Neal, who's a Senior Director of Vascular Epidemiology and Preventive Medicine. He's a Professor of Medicine at Sydney University. And when we come to ask these questions, you will be able to ask questions not only of the speakers, but I would hope that Professor Neal, he's going to be with us this morning, so could answer, as well as Dr. Bandara and Dr. Cranfield. So I really want this to be an opportunity for you to ask questions. And as I said, I'm on a steep learning curve here too myself. You know, the more you learn, the more you realise you don't know. And that's part of the joy of learning and health, in fact, in general. So there's slight change to the program in that because I'm already on my feet, I'm going to lay the foundation and present the case for water fluoridation. And the definition is quite straightforward, really. It's the process of adjusting the fluoride content of water to the recommended level for optimal dental health. I mean, that's the concept. And it's worth noting that fluoride is the 13th most abundant substance, and it is found in the water supply in concentrations which vary from 0.08 part per million to 25 parts per million. And it's also found in soil and in common foods. It prevents tooth decay in all ages. It's a safe, legal and ethical way of providing a benefit to everyone, especially those who are disadvantaged. There's a socio-economic issue here. Despite fluoride in the toothpaste, there's still substantially more tooth decay in non-fluoridated areas compared to fluoridated areas in New South Wales. Now, in summary, it's safe. No identifiable harmful side effects. It's effective. It delivers proven tooth decay reduction. It's efficient. Better than any other methods of fluoride delivery in the water supply. It's cost effective. For every dollar that is spent on this, one is said to save 30, 40, maybe even more dollars in dental health costs. It's equitable. It transcends socio-economic barriers that might prevent the use of other decay-preventing products. And just to give you a little bit of background, because not all that many of you may be familiar with how teeth actually develop, and the term we will be hearing today is decayed missing, DMFT, decayed missing filled teeth. And there's another term which is decayed missing filled surfaces of teeth, because a tooth has 6 surfaces. It has a biting surface, it has a cheek surface that faces the cheek, it has a surface that faces inwards towards the palate and the tongue, it has a surface that faces towards the midline, and it's another surface facing towards the back of the mouth. So there are 5 surfaces, and the 6th surface is, of course, the root of the tooth. So when we look at a newborn baby, and then this is how teeth develop, the theory, of course, is that fluoride is incorporated into tooth structure and makes it less soluble to attack. And as we look at teeth, for example, the teeth of somebody who is 5 years old will have 20 teeth in their mouth. So 20 teeth, oops, hang on, I knew I was going to do that. Okay, here. So this is go forward. This is a 5-year-old, and a 5-year-old will have 20 teeth in their mouth. By the time you reach 10, although it doesn't look like it there, you may have 24 teeth in your mouth. And after the age of 10, after the age of around 12, 13, when the second molars or 12-year-old molars come in, you will have, or you may have 28 teeth in your mouth, and the full 32 complement comes when the wisdom teeth come through. So if we have 28 teeth and there are 5 surfaces in 28 teeth that could decay, gee, can someone quickly do the maths on that? There are quite a few surfaces in the teeth. So that's important basic knowledge for you to be aware of. The number of teeth in a 5, 6, 7, 8, 10-year-old, 12-year-old adult's mouth, and the number of surfaces. And here is a 10-year-old where you can see the 6-year-old molars, the adult teeth through. You can see the adult teeth developing. These are adult teeth. Here is the 12-year-old molar, and there is what the wisdom teeth looks like in the mouth of a 10-year-old. Okay, just developing. I just wanted to give you some basics because you're going to be hearing terms today that you may not be, and we make assumptions that you're familiar with. DMFT, number of teeth, da-da-da-da-da. Hey, what does that mean? And here is the full complement of 32 teeth in an adult mouth. And here is a filled surface. Here is another filled surface. Here's another filled surface. Here's another filled surface. So here's another one. So the number of decayed, missing or filled surfaces in this person's mouth may be 2, 4, 6, 8, 10, 12. There may be 14, 16, 18 surfaces of teeth decay. Okay. And of course, one of the issues with fluoride is fluorosis. We all acknowledge that. And fluorosis is a discoloration of teeth. Now, looking at the top left-hand screen, that is what is considered normal dental appearance. And as we move to the right-hand side, that would be what might be considered mild fluorosis, discoloration, and then moderate in the bottom left-hand and severe in the bottom right-hand. So fluorosis is an issue in fluoride water fluoridation. And I think it's fair to say very much dose dependent. Now, again, basic anatomy here, this is a tooth, okay? And a tooth is covered by enamel, and underneath enamel's dentine. And the way decay occurs is you end up with a little pinhole. That's what your dentist is doing, feeling around for cavities, and it goes through the enamel, spreads into the softer dentine, and that's how a cavity develops. And tooth decay, of course, is a combination of diet, very much so, the plaque build-up and a susceptible tooth. There are other genetic factors and salivary factors and all of this, but basically, you know, the substrate is our diet. We have over 500 different species of bacteria in the mouth. It's essentially a struggle between good and evil, like most of life. And when we eat foods that are high in refined carbohydrates particularly, juices also, then we have a substrate which the bacteria that causes the problems produces an acid, and that acid makes a hole in the tooth. And here's what it looks like when the dentist takes x-rays. I mean, the shadowing here, 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 here. This is what tooth decay looks like. So, this isn't a stretch. This is something I feel very passionate about. Healthy mouths and healthy lives. We are the gateway to the digestive tract, to the respiratory tract, the site of the 2 most common infections, huge neurological input. I mean, the mouth is a critically important part of everyday health. Poor dental health is associated with poor general health. Lots and lots of links to show that. Healthcare costs rise with oral health costs. I mean, if the hardest structure in your body decays because of what you eat, just imagine what's going on to the rest of your body, and it may well explain why we have such high degenerative diseases in our society. The good news is that dental disease is preventable, and that is certainly true. Oh, and I've just turned the screen off, but I've turned it back on again. Now, this is, where did it all begin? And this is the father, if you like. Well, there's probably other fathers, but this is one of the fathers of fluoridation. Trendley Dean was a researcher in the United States and did some research in the 1940s, which was considered landmark research, where well, here's the summary of it, basically, and we could go into research ad nauseum, but the key here is that he explored, he took a sample of 7,257 people, children over 21 cities in the United States. And, you know, one always needs to look at that kind of statistic very critically. What was the actual cohort? But anyway, this is the statistic as is presented. And the trend is clear. The trend is very clear. And that is, as the level of fluoridation in the water increased, the incidence of this term that I wanted you to be familiar with, DMFT, decayed, missing and filled teeth, went down. So, mind you, this is decayed, missing and filled teeth, not decayed, missing and filled surfaces. So that's another term we need to be familiar with. So there is a very clear trend. And repeated in other countries around the world, this kind of idea that as fluoride was increased in the water supply, the DMFT in a child went down. Now, when one looked at the incidence of tooth decay from 1945 to 1965, it was a little bit all over the place, not showing any clear trend. And when fluoride was introduced into the water supply in Australia in 1968, in Sydney, that's when, I think it was in 1968 that it found its way in Sydney, these kind of graphs almost reinforce the idea that water fluoridation has been described as one of the most successful public health measures ever undertaken. Now, in New South Wales, the coverage is 96% of the New South Wales population receives fluoridated water. Sydney water has been fluoridated since 1968, and the concentration is 1 part per million. Now, again, we could go through study after study after study, but I would like to draw on this study, which was authored by the Professor Evans at Sydney University, and it was published in the Australian Dental Journal in 2009. And what it compared was two areas. It compared the Hawkesbury, well, let me just get rid of the box and underline here what I'm talking about. So the Blue Mountains was not fluoridated until 1992. The Hawkesbury River, like the rest of Sydney, the Hawkesbury Basin, was fluoridated since 1968. So it seemed to provide a very good comparison in a very close geographical area to the fluoride and non-fluoridated areas. So in summary of some of the results, now here. Now looking at primary teeth, 6 to 8 years old. Now remember I said 6 to 8 year old will have probably about 24 teeth. And so remember the yellow is the group that has been fluoridated since 1968. And the blue has not been fluoridated until 1992. So these 6 to 8 year olds had a lifelong, they'd lived in the area, that had been corrected, and they had now lifelong exposure to fluoride. And so the result shows that the amount of decayed, missing and filled teeth was 2.5 out of 24 teeth in 1993, and compared to the fluoridated area, which had 1.1 decayed teeth. And in 2003, after 10 years of fluoridation, this was the result. There was a decrease, obviously. And one thing that's always lovely, and you need to be aware of this when you're reading research, if I was to say to you there was 135% improvement, which is exactly true, a difference rather, down here, right? 135% more at baseline. So huge, huge change when you look at the percentages. And then we look at the permanent teeth. Now these are 9 to 11 year olds, and again, the number of decayed, missing and filled teeth, 0.58 missing filled teeth in the fluoridated areas, and of the 24 teeth in the person's mouth, 0.8 missing and filled teeth. So, and then of course, looking at it 10 years later, there's a significant improvement actually in both groups. And then we look at percentage of lifelong residents with no decay at all. And in the Hawkesbury, in the Blue Mountains area where there was no, again reminding you where there was no fluoride, 61% of the population had no cavities at all, and in the fluoridated areas, 71% of the population had no decay at all. And 10 years later, both the fluoride area and the non-fluoride, and now the newly fluoridated area, had risen to 87%. Okay, 81%, 87%. And finally, I want to leave you with this diagram, which is the source. It's a World Health Authority. You can look this up. The reference is there. I'm happy to share it with you. But we see this kind of diagram, and these are 4 countries that had fluoridated their water, and the trend is clear. So I'm going to leave you with that as the case 4. It's a naturally occurring, apparently ubiquitous chemical which is present in the water supply at varying degrees naturally, and it has shown to reduce tooth decay by various studies, and I've picked one that I know Professor Evans has presented to James Cook University up in Queensland just last year, so I assume this is as good a reference as I could find. And at the end of the day, it's a balancing act. The good, to do good, to avoid harm, to be fair, respect individual choice, that's certainly important, and the minimal burden to others. So with that, I'm concluding, and as I say, I do apologise to you for not, I had mentioned to the Sydney University that I knew somebody would be able to present far better and more compelling case than I have. But I think I've kind of introduced you to some terms that you should be familiar with. The DMFT, the decayed missing and filled teeth, the DMFS, decayed missing and filled surfaces, is also a very significant thing. So we're going to move on in the program, and amazingly I think we're actually running a little bit ahead of time. Maybe we can continue that on through the day. The next speaker, and let me just